we are so lucky to have a guest here that is sort of like, if you're a fan of hockey, it's like interviewing Wayne Gretzky. I honestly couldn't sleep. I was thinking about this.
I've never been compared to Gretzky, and
No?
I'm just thrilled. I'm getting my skates out.
Hello and welcome to the Hat Rack. My name is Dr. Bill McCauley. You can call me Bill. I am the Associate Dean of Continuing Professional Development and Faculty Development at the Schulich School of Medicine and Dentistry in London, Ontario, Canada, for those of you that are listening from outside. And joining me today is my colleague from the Continuing Professional Development Office, Leslie McAdam.
Hello, everyone. I'm the Program Administrator at Continuing Professional Development at Schulich School of Medicine and Dentistry.
So this is our inaugural episode of the Hat Rack. Are you nervous?
Maybe a little bit.
Okay, this is the first. Have you ever done a podcast?
I've never been a host on a podcast, no. So this is great.
But you did some training in podcasts.
Oh, yes,
Yeah.
yes,
Okay.
yes. CPD put me through some training.
There we
Yeah.
go. Okay, that's good. That makes one of us. So the Hat Rack is the name of our podcast, and it's a podcast that's aimed at physicians in practice to help them to understand a little bit more about continuing medical education and maybe, we hope, how best to organize their CME to suit their practice needs. So we came up with the name of the Hat Rack. What do you think of that name?
I think it's a great name, right? You do want something to put your hat on.
Right. So that's where the name came from. So it actually came from a surgeon that supervised me back in the 1980s when I was in medical school, whose name was Bill Jameson. He was a vascular surgeon. He's fortunately passed away now, but he was one of these surgeons that had lots of little quippy sayings, and he would always take us on rounds and always give us something to hang your hat on. I know he didn't coin the phrase, but he used it a lot, and I sort of associate it with him. So when we thought about a podcast like this, we want to give some practical tips and advice to physicians in practice, and so some might call them pearls. We're going to call them something to hang your hat on. Okay, so we're the Hat Rack.
Yes.
All right. Okay, well, we are going to get on with our first guest, and we are so lucky to have a guest here that is sort of like, if you are a fan of hockey, it's like interviewing Wayne Gretzky. That's how excited. I couldn't sleep last night. I honestly couldn't sleep. I was thinking about this. So our guest is Dr. Dave Davis, and Dr. Davis started out his career in CME quite some time ago. And he started and this was fairly inaugural, he started as the chair of an interprofessional continuing education program at a community hospital. And this is back before, I think, interprofessional was even a thing.
Right, yeah.
Right? So he was chair of that, and then he went on to become the chair of continuing education at McMaster's Faculty of Health Sciences. From there, he jumped to the dark side and went to the University of Toronto and was the Associate Dean of Continuing Professional Development and was a founding director of the Knowledge Translation Program there. He also, and I want to hear from him a little bit more of this, developed a comprehensive provincial competency assessment program and helped launch what I think is quite a now prestigious Center for Faculty Development at the University of Toronto, which is a fantastic organization that looks at faculty development. He then was lured by people in the United States to the Association of American Medical College, which is, I guess, the American equivalent of the AFMC, the Association of Faculties of Medicine in Canada. So I'm getting tired just talking about all the things that he's done. He also was the chair of a couple of big organizations related to CME in the United States. One was the Alliance for CME, and the other is SACME, which is the Society for Academic CME, which are two big, heavy-hitting organizations. So we are delighted to have Dr. Dave Davis with us, who's going to share with us his thoughts about CME over the last X number of decades. Welcome, Dave Davis.
Thanks, Bill and Leslie. It's great to talk to you today. I've never been compared to Gretzky, however. And
No?
I'm just thrilled. I'm getting skates.
I can't believe
I'm getting
that
my
that's true.
skates out. For the rest.
So a couple of things that weren't in your bio that are kind of interesting, I think are important for us, is that you are a Western grad.
Absolutely. 1967. We just had
1967.
our 55th reunion. Can you imagine?
I was going to, and were there a lot of, I hesitate to ask, were there a lot of people that came?
Yeah,
to
about a
reunion?
third of the class. We had 60
Wow.
graduated, and about a third of us came. It was awesome. So I have really fond memories of medical school. Some of them to do with the education, mostly just to do with the classmates and the milieu. And it was quite a traditional medical education, and so it inspired me to think, not always positively, about how we might improve medical education. I'll tell you a little bit more about that. But I'm a proud Western grad, I'll tell you.
That's fantastic, and that's great for us. It makes it even more special that you're our first guest here.
Thank you.
And the other thing that I've left out, which I think is really important because it gives you some street cred, is that you, through all of this, you had this academic career in CME, and you were, I think, what we would call an influencer now, but you were definitely an influence. But through all of that, Leslie, he practiced family medicine for 40 years.
Wow. So 40 years and doing everything that we just spoke about. So how did you do that?
Well, I was very lucky. I had a great partner in Burlington for a large part of the time. So she and I shared a practice in a group of about 10, and then went full-time with McMaster University and subsequently with the U of T. And those two roles permitted me to continue my practice until with a team around you. So around me, it needed a team and residents, of course, in both of the teaching positions. So it looks impressive if you think I'm working full time as a family doctor, but in fact, I was supported a lot to do what I thought I needed to do for others as well as for myself, of course.
Well, I still think that whether it's full-time or whether you're doing it part-time, I think that it's important to have that credibility and understand what it's like to be in practice and understand what the issues are in practice that are impacted by CME and how to understand practice. Because I think a lot of times when physicians in practice are thinking about academics, they don't think that they really have an understanding of what goes on in real life. So having that ongoing longitudinal practice, I think, would have been really helpful for you.
I sure had a sense when I was not academic. I sure had a sense of those guys in the academic world loafed, right? They came in at 10 o'clock, had coffee till 11, saw a couple of patients, and broke for lunch. That sure wasn't true. I was, in terms of practice life, I was probably just as busy, in some ways busier, when I was in a university environment as opposed to being solo. And the patients, of course, always the patients are the same patients. So, I learned a lot from my practice life.
So let's start by hearing a little bit about how a community-based physician got involved and interested in continuing education.
So I trained in a day when family medicine residencies were so new that the dean of the day suggested to me that I could go directly into practice after a rotating internship just as easily as in his words, newfangled family medicine training would allow me. So I did that. I did a rotating internship and then went into group practice setting in Burlington, and within about 8 seconds decided I don't know enough. I knew lots of the academic stuff. I knew anatomy, physiology, biochemistry. I knew in pharmacology, was a fairly good student, and did okay during my internship and learned how to deliver babies and all that sort of stuff. But somebody came in with a cough, and I thought, my goodness, I need help. So I looked around thinking, well, continuing education's out there, so I should do it, and started to sign up for courses. I probably signed up for more courses in my first year than not that I practiced, but I signed up for a lot. And I got the feeling that it was specialists talking to family doctors, general practitioners in those days, about what they did as opposed to what the family doctor, general practitioner was doing. I remember one lecture at the University of Ottawa where an orthopedic surgeon told us how he did his hip surgery. This is pretty useless for a GP to know what I wanted to know is when to refer and what to do until the referral happened and how to help patients lose weight and that sort of thing. So Joseph Brant was a fairly large GP department and had some people in it who were pretty innovative in their thinking, including something called chart review. So once a week for about an hour, hour and a half, you'd bring in charts and you'd review them. Somebody who was the organizer would call you up the day before and say, can you bring in the 3 first charts that you saw, first patients that you saw, or the last 3, or the ones that you scratched your head about? And every week that went on, and I learned more in that week and learned more about myself, in that hour rather, and learned more about myself and my practice than I did in all the standard continuing education. So we formed,
So was someone else reviewing your charts?
Yeah, so it was a group.
Yeah, okay.
So there were about 20 of us, of whom maybe 10 or 12 would show up every Wednesday morning. And one of
get
us
direct
would,
feedback?
And it was feedback, right? Oh. And, helpful hints from guys much more senior than I. I was still pretty brand new. But it got me thinking about continuing education. It got me thinking about how could we do this a little bit better. And along the way, somebody said, we need a committee. In that typical of doctors, we need a committee. Where 3 are gathered together, there's a committee. And that in fact happened. And we decided, not me, but the chairman decided that we would have a nurse and a physical therapist and an occupational therapist, and other health professions on it. So it became an interprofessional committee, and eventually that individual, Jack Sibley, became the dean for education at the brand new McMaster University. And I was named, for reasons that are obscure to me, I became the chairman of that committee and did some research then, and then moved to McMaster University.
Wow.
Yeah.
So putting a nurse and a physiotherapist on that committee, that would have been quite a number of years before interprofessional practice terms, or even though people worked in teams back then, it wasn't really recognized or taught about that or talked in that way, right. I don't think, was it?
I can remember a surgeon saying to me, so you're expecting you're going to have a nurse on this committee? And I said, yes. He said, if a nurse is teaching me, if she's in the room teaching, I know I won't learn anything, so I won't be coming to your rounds. He eventually started coming to our rounds. So this is very interesting.
He started coming to the rounds and was an active participant and
exactly,
was engaged.
Yeah.
Wow, what a victory.
Yeah, you go for little wins, right?
Yeah, I'm interested in what you were saying, that you went to lectures. So was that what CPD was?
Correct. That's right.
Went to lectures?
That's right, Leslie. It was virtually all a day or 2 days or 3 days of lectures, stand up, sit down, with a minimum amount of time for questions. And the questions were not programmed so much as they were fed to the professor or fed to the specialist in a way that didn't help us particularly. I thought at the time when I went to the lecture, that's a really good idea. So I wrote that down and then didn't look at my notes afterwards. It just didn't seem to relate. One of the breakthroughs for me was going to a continuing medical education lecture in which the moderator was a family doctor, and he or she could bring it to the level of the primary care clinician. That was very useful, but most of it was lectures.
So then you joined the faculty at McMaster, or maybe you were already part-time faculty, but you became McMaster. And that was a time McMaster's medical school was quite innovative. At the time, it established certainly Canada's first practice-based curriculum, or problem-based medicine, I think is what it was called back then. It was fairly innovative. So it sounds like there was a lot of energy at that time for innovation in education.
Absolutely. So whereas what excited most of us was clinical topic areas So something new in cardiology, something new in nephrology. This added to that. That was all of that mix at McMaster, of course. Brand new Department of Psychiatry and all of that. But two innovations. One was in family medicine. So family medicine was chaired by a community-based family physician. And so that was very innovative and new, with a broader outreach and a sense of interprofessional education and a sense of the community. But mostly what excited me was education was also an exciting topic. So you could sit down at coffee or at the end of the day and talk about an educational idea, like how can we bring family physicians up to date? How can we help them most? What would research look like? And remember, this was the school that had the first large department of epidemiology and biostatistics. So these were guys who were trial designers, and talking to them opened my eyes as well. So it was great. So I had, for a period of 10 years or so, I had an appointment as director of CME, so I could talk about the educational things at the programs, and did the research, and could also practice so that I felt I was credible in both areas.
Mm-hmm. I want to jump forward a few years then, because you then transitioned to the University of Toronto, and while you were there, you were the lead author on a sentinel paper, really, in continuing medical education. It was a systematic review that was published in JAMA in September of 1995. I personally did a master's in health professions education at the University of Illinois Chicago, and that paper formed the basis of my own thesis in the work that I did on CME. So I'm interested to hear your thoughts. All these years later, we're almost 30 years down the road now from that paper. What do you think were the big messages that came out of that paper? Because it was sentinel. It changed a lot of the way people think about CME.
I think the first thing to say, Bill, thank you, and I'm glad it inspired you. It inspired my wife to say, when are you going to get it done? Because the dining room chairs are full of these papers. So I'm glad it inspired others in an academic way as well. So a couple of things to say. One was, we define CME differently. Most people, when you say CME, if they know what it means at all, think about the lecture, right? Just as Leslie said, that's what CME was, right? So I've got 14 hours of lectures, and I'm going to go to Ottawa and sit there and take notes, and that's what I've got. We defined it in a whole variety of ways, including audit and feedback and reminders at the point of care. We even included patient reminders, so mailing a patient a reminder that it's time for her mammogram, for example, and having her then make the appointment to see the doctor. Did that change behavior? Opinion leaders, those are key influential individuals in your community in a specialty or in primary care. So we defined it broadly. We also included chart audit and that sort of thing, as well as lectures. And then we measured, not were you happy with the chicken soup and the lecture, but did you change your performance as a result of the continuing education intervention, and or did it change healthcare outcomes? And when we put those two things together, we looked at 99 trials, hence my wife's desire to clear out the dining room, because it was in the days before computers, and so they were all hard copies sort of thing. When we looked at those things, the things that really worked were reminders at the point of care, and opinion leaders, and outreach visits, something like the drug rep, but an academic drug rep, if you will, and sort of multi-pronged interventions like a lecture plus a reminder plus something else. Things that didn't work very well were, no surprise, were lectures, particularly didactic lectures, not case-based, and particularly those that didn't allow interaction. So it was talking head or the sage on the stage. So those didn't work very well to change physician performance or healthcare. So that's what we learned. So that's from the provider side, and I learned a lot I learned a lot about trial design, randomized control trials, and systematic reviews, and all that.
My thoughts about that are that it shouldn't be surprising to us, although it was, I think, a very significant paper because prior to that, and maybe to a certain extent, although much, much, much less so still these days, a lot of physicians think about CME as the conference or as the lecture. Certainly that was the case in the day. But if you were to go and ask a physician, think about the last time you actually made a change in your practice. Think about why you decided to prescribe a different drug or take a different approach to diagnostics or try a different procedure, and think about what were the things that influenced you to do that. And certainly I would be surprised if anyone said it was because of attending a lecture at a conference. And I would also be surprised if most people didn't say, well, it's because of talking to a colleague or seeing what someone else does in their practice, and some sort of direct personal interaction that actually caused me to try this new medication. Yeah, I would look into what the literature was on the intervention or the prescription or whatever, but it's really the influence of peers that really is a strong driver of things. And a lot of the things that you're describing outside of conferences are, as you say, personal interactions with individuals.
Right, Bill. I agree with you. I think, thinking back about the changes that I made, it wasn't one lecture and it wasn't one thing. Generally, it was a series of things. A patient outcome that was less than desirable, plus some reading, plus talking to a colleague, plus one of the chart audits or chart review sessions that I talked about previously. I think it's all those things. So, and it's very much directed by the physician. I think if there's any message here, it's be your own CME director, right? Oh, yeah, that's quite powerful, isn't it? About our own learning.
What do you mean by that? Be your own CME director?
Yeah. So I think So it struck me that there are two or three things that somebody said to me once. So what advice would you give a younger physician about continuing education? One, I think, is a sense of being in control. That is to say, our practice life and our educational life shouldn't be separate. There's a sense in which, so my practice is over here, and I'm going to go to the Holiday Inn or to the university lecture hall and learn something. They really should be, I think in my mind, what I've learned is that you're learning all the time. You're learning from your patients, you're learning from your colleagues, you're learning from the journal that arrives that week. So you're learning all the time. The second thing would be, I think, to build in some time for reflection. So it needn't be long. My partner in Burlington is one of the best physicians I ever knew, full stop. Always booked 20 minutes or half an hour at the end of the day to write up her notes. She'd put in the things at the time of the patient visit, like blood pressure, for example, that she couldn't remember later. But then she'd write up the note. And during that write-up, she would think about many things, including what it is she might need to learn. So I think those things, plus being able to relate to others. One of the other studies that we did was on the ability to self-assess. Again, in other systematic reviews, we found some trials comparing what you believe, what we believe about ourselves to what others watch us do to observe performance. And it looks like we're really not able to self-assess very well as humans, not just as physicians. True in all professions and true among humans for a variety of reasons we can talk about. But I think that just speaks to the need to have some kind of group around us, whether that's your practice colleagues or a small group learning activity that the college does in primary care, or some other venue where you can share your results and get feedback is very powerful.
Interesting. I was interested in your concept of the sort of being a CME director because we spend 40 years in practice. And during that 40 years in practice, we don't really have a curriculum of learning. I mean, we go to medical school, we do residencies, we've gone to high school, elementary school, preschool, and there's always a curriculum there. There's a curriculum that is applied for you, and then you finish, and I use finish with air quotes, and you start in practice, and the expectation is that you then develop your own curriculum. But I don't think people think of it that way. I think people think that, as you said, that education is something separate and not part of the practice. So how can a physician who's always been given a curriculum then turn around once they've been let loose and certified by everyone that can possibly certify you? How can that person then develop their own personal curriculum of CME that's going to take them through their career?
Yeah, you're right. I think there is a sense in which I was told this, right? So as opposed to something I learned myself. So I think one of the things in the new medical education, you have a master's in education in the health professions. Bill, and I know Leslie thinks lots about this too, but I think one of the advantages of the newer medical schools is, in fact, that we'll provide you with resources, but you are the conductor of the orchestra. You with help, with feedback. That feedback, of course, is pretty heavy in the first 2 or 3 years of medical school, and a little less as we move towards clerkship and a little less in residency. And ultimately is almost entirely ours, right? But I think it's something that we as medical educators, I certainly felt that way when I had residents under my supervision, that they together, we kind of co-created the curriculum. So what do you think you need? I might say to a resident, so what do you think you need in order to accomplish this particular rotation successfully? What are your learning objectives? How are you going to meet them? And along the way, I'll provide you with some feedback about things where I see learning gaps. So I think that's coming for all of us. I think it's necessary for all of us, particularly in a day when we're snowed. I mean, talking to my colleagues in family medicine today, they're snowed. It's a very difficult time. This is post-COVID, and of course, and I think the snowing phenomenon happened earlier, but COVID hasn't helped any of that. And I think the pressures on them, on all of us, are extraordinary. So being in control, at least of your learning, among other things, is helpful.
Great.
Yeah, so your own personal curriculum, that's good advice for sure. And you've mentioned numerous times about continuing learning, and that goes on throughout your whole career. And you've been in this for 40 plus years, and we have continuing professional development, continuing medical education, and we put the continuing right at the front. So how are we doing with that? Are we able to get that message across that we do need to keep continuing our education and changing as we go along?
I think it's better than it was. I remember visiting a doctor visiting me, referred by a licensing body many, many years ago. And he had never been to a continuing education event. And I said to him, or activity, or read. It had never occurred to him that on his graduation, he just had the tools to continue to learn and practice. He thought he was done. That's a very unusual phenomenon today. Partly because medical science evolves and develops and changes so much, right? But also because I think the medical education curriculum is such a problem-based curriculum. It inspires you to continue to learn. So I'm impressed with the best of the physicians who continue to do that. So I think we're doing better than we were. Can we do better still? Yes. Can continuing education offices provide a wide variety of learning, a wider variety than just a lecture? Yes, they can, and yes, they're doing it. I think the Canadian medical schools are doing a really good job of that generally. Can we do better? Yeah.
So I'd like to know a little bit about your thoughts on how things have changed. So how things have changed in continuing education and continuing medical education in particular over the span of your career, and where you see it going, or maybe where you hope it's going to go.
It's a really good question. So although I was Mr. Optimistic and said that all continuing education offices are now providing more resources, I think the way in which we count continuing education still by hours defeats some of the purpose. So I need to get, for my college, I need to get 50 hours per year, say, right? And how do you count hours? You count hours by sitting in a seat somewhere, lecture hall, going to grand rounds, some of which might be very useful, and I think the lectures are getting better and we're more interactive and more case-based than we were. But that still lets us off the hook about, what about the 3-second thing that I do when I go on my computer and search the side effects of a medication? What about the 3 minutes that I spend reading up on something? What about the 3 hours when I've got a patient I'm really struggling with and I need to do some reading around that? What do I do with it? Can I record? Yes, we can kind of record that, but still CME and the way the professional colleges organize their CME, counting the CME sometimes deflects that. Now, the College of Family Physicians of Canada and other colleges, SOGC, have moved away from that, but I'm not sure that that's penetrated in the way that I would like to see it. So I'm saying a couple things to you. One is how it's changed, I guess, over time, and saying to you pretty clearly, I think the colleges need to get to that next level. The measurement is still a problem, and you know what they say about medical school, we teach to the examiner or learn to the examination, right? So is this going to be on the exam or not? It's going to be on the exam, I'll learn it. And I think we're guilty in the colleges, professional colleges, of doing some of that thinking.
I'm really glad you brought up the concept of the point of care learning, because I also think that's a problem for physicians in practice, maybe not recognizing or being mindful of the fact that that is continuing education, that when they are taking their computer in their hand, they're looking up something on their cell phone on UpToDate or whatever that is they happen to be using, and finding information that changes their practice in the time, in the moment, because they've learned something about what drug to prescribe when someone's got an allergy to so-and-so. How do I approach this? That's point of care learning that people don't recognize as learning. I think people just think that's part of what I do, and it is, and it goes back to your concept of integrating professional practice and education together. And I think you're right. The accrediting bodies or the credit counting organizations that are out there need to do a better job of not only recognizing that that's learning, but encouraging physicians to think about that point of care learning as an integral, important, and vital part of their practice.
You've had time in that world to build a professional college world and with significant impact, I think, on how continuing education is delivered. It's kind of dichotomous, isn't it? On the one hand, we've got the CME provider and the resources, and on the other hand, we've got the doc and how he or she learns and their own practice environment and milieu and all of that. I think when I think of those two almost dichotomous sort of elements, I try to picture what the patient has to say, sort of picturing the doc and the patient together in the interview room or the emergency department, and the real learning happens there. So if we can think of it that way, and we can help the colleges and ourselves think of it that way, then I think we've got the heart of continuing professional development.
I think that's helpful.
Do you have any tips for us to make CME more effective? What would you give to some advice to practicing physicians? How can they make it more effective?
Yeah.
This is we need something here for docs to hang their hat on here.
I started talking about it a little bit. The first, I think, is to think of yourself as not being alone in all of this, right? So you've got colleagues down the hallway. I talked a little bit about the chart audit and the chart review time. And I mean it. It was the most important learning for me. So if you can build, if you, the family doc, or emergency room physician or general internist, can find a place to do that, do it. It's probably one of the best things you can do. The other thing is, we said this earlier, think of yourself as your own CME director. like the conductor. So you've got, on the one hand, you got patients and their needs, right? And sometimes there's a gap between what it is you know and can help provide the patient. That gap is an important trigger for you to cue the resources, if you will, for your own learning. And the third is to build in time to do that. And that's really easy to say. I had great intentions when I started in practice about, and I'm going to build in 3 hours a week for reading. Wow. Where did the 3 hours go? They were looking after kids and being with the family, for example. But if you can do it even 10 minutes at the end of the day to do that, that's really important for you. And maybe the last thing is, don't think of CME. We've touched on this too. Don't think of CME as just the lecture, but think of it as all those resources. Just think about the last changes that you made. And those are all important resources. So value them, maybe labeling them away, acknowledging that they exist, and using them in a way that's useful for you. So those would be my 3 or 4 tips.
That's very useful information, not just for docs in practice, but I think for those of us that organize CPD, because I think that we can be guilty of doing what's easy, and what's easy is organizing the conferences and not making the tools available to help physicians to do those things.
Right.
And I think that's something that we need to keep a focus on. So, Dave Davis, thank you very much for your time. This has been a real treat for us. We are dipping our toes into this podcast water a little bit gingerly, but you have made this phenomenally easy and extremely rewarding. So thank you very much for your time.
Leslie and Bill, thank you for the time and for being interested in continuing education. So
Great.
There you go.
And so thank you very much for listening to our first episode of The Hat Rack. If you have questions for us, then you can find our emails on the website of CPD at Schulich School of Medicine and Dentistry at Western University. We're interested to hear your questions. If you've got suggestions for topics or suggestions for guests that you'd like to have, we'd be happy to hear about them. And we look forward to seeing you next time. Leslie, how'd it go?
Good. Great. Thank you so much, Dr. Davis, for coming out. Nice to meet you. I've heard about you the whole time I've been at CPD.
Yeah, you're welcome. It was great to meet you both, too.
Great. Have a great day.
Thank you.
You've been listening to The Hat Rack, hosted by Dr. Bill McCulley and Leslie McAdam from Continuing Professional Development at the Schulich School of Medicine and Dentistry at Western University in London, Ontario, Canada. Technical assistance for The Hat Rack is provided by Patrick Barfoot, Technology Support Specialist at Schulich. Original music was composed by Cameron Bereznik. Please contact us with any questions, comments, or suggestions for future topics or guests. We can be contacted by email at thehatrack, that's all one word, THEHATRACK, at uwo.ca. Additional episode information can be found online at www.schulich.uwo.ca/CPD. For The Hat Rack, I'm Stephanie Giberson-Kirby, Faculty Development Specialist at the Schulich School of Medicine and Dentistry, leaving you with something to hang your hat on.